What's going on, everybody? Welcome to yet another episode of the Core Consult RX podcast. Cole and I are missing our buddy AJ tonight.
We are.
I think he started school back, so we figured we'd give him a break.
You know, he's not the only one who started school back. Everybody else in Charleston did, and so traffic is bad again.
Oh, it's terrible.
It's so sad.
Yeah.
The summers are great. Traffic is slim. You get where you need to go. You get used to that.
Yeah.
Then August happens, and you remember what it was like.
Right. Remember when COVID first happened, how there was zero, like driving to the clinic and stuff like that, how little traffic. It was nuts.
Oh, yeah.
It was crazy.
Oh, it was amazing. But, interestingly, there was a lot of car accidents, even during COVID, because the roads were free. So people were driving like you for the most part.
There's no rules. First of all, that's outlandish to put that on record as if I don't obey the traffic laws.
I know you're a stickler for this.
I am very much so. I have a governor on my car. keep me from speeding. So we are doing an episode tonight that is once again accredited, ACPE-Accredited for continuing education for our pharmacists and nursing colleagues. Again, thanks to freece.com. We've partnered with them, and they've had us back once again. We're steadily building this library of accredited episodes. I'm liking it. But this is a accredited episode, so for those of you who are members of freece.com and have unlimited membership accounts, then after you get done listening to this episode, go to the link in the show notes. You'll be prompted to enter a secret password. Don't tell anybody, but it's vaccine, all capital letters, and then you'll take a post-activity test. Pass the test, you get your credit for 1 hour, and you get to keep your license another year. So that's good news for everybody.
It's great.
If you're not a member of freece.com, as we've said many times, please check out their library of various monographs. They have live CEs. They have podcast episodes that are okay. It's us. Okay. See what I did there, Cole?
Spoiler.
Yeah. And
humble brag.
Yeah. And all kinds of other really good content on their website. So having unlimited access, unlimited membership rather, it gives you access to all of it. And it's very convenient. And so definitely check that out. And we also have a discount code in the show notes as well. There's a link that'll take you to the checkout and give you a discount code to get that unlimited membership. And then you can learn as much as you want. It's unlimited. So definitely check them out. Thanks again to freece.com. We really appreciate them continuing to work with us.
It's funny how I'm digressing, by the way.
Oh, cool.
It's funny how we say during COVID, like the streets were clear, as if it's like a period of time, like a set period of time during COVID.
Yeah.
It's like the prehistoric era.
Yeah.
Eventually that we'll refer to it that way. It's like the COVID era. The 2 years or whatever it ended up being.
Yeah, definitely. I guess, because technically it's still here. But
what do we mean by that? We mean during the restriction, like when people were at home.
When we had no idea what the heck was going on or how to treat it or what to do.
That's what during COVID means.
Mm-hmm. Yeah, that's a good point. I'm glad you brought that up because we would have inevitably gotten
Not that we needed to clarify everybody understands, but we
would have definitely gotten one email going, "Oh, what, you think COVID's gone?"
Well.
Yeah, we would have gotten at least one of those.
It's for posterity for when our future generations are listening to this episode and saying, "What do they mean by during COVID?"
Oh man, could you imagine if future generations they had nothing better to listen to than us? That would be terrible.
Their ACIP guidelines are so out of date.
Well, it was recorded 75 years ago. Oh, geez. Well, hopefully there'll be, I seriously doubt podcasts will be a thing 75 years from now. It'll just be like something you implant in your head and upload all the information like the Matrix or something.
Yeah.
Probably.
Speaking of which.
Yeah. Speaking of the Matrix.
We're about to upload some information to your brain.
Let's talk about vaccines. So we haven't done a vaccine episode, since like the 30th episode in the 30s somewhere?
4 years.
4 years?
4 years. A lot's happened in 4 years.
Yeah. Like the podcast. I think we started, 4 years?
4.5.
2018. Oh, dude, is this going to be going on? No, this will be 4 years, right?
Yeah.
You think we know how long we've been doing this?
I know. I got to go back.
We're at 3.5 years right now.
I'm pretty sure the first official one was January 2018.
Yeah.
We might have dabbled in a couple things the end of 2017, but really it was January 2018.
Oh,
so
jeez.
Yeah. We're coming up on 5.
Yeah.
Whew. That's half a century.
A century?
Half a decade.
Yeah. I was going to say, are we sure about that? Yeah, we're not really good on terminology when it comes to dates. That's one of the things we struggle with here at Core Consults RX.
Or Greek.
Yeah, whatever it is. Roman numerals.
Roman. Okay.
Yeah, we speak Roman.
But yeah, we mentioned the code was vaccine. So we're talking about vaccines. We're talking specifically about the updated ACIP guidelines for 2022, right?
Yep.
Yes. So since we've done vaccines, there's a lot of new stuff. COVID vaccine, for instance, new pneumococcal vaccines, various different recommendations related to vaccines that we already have. So we're going to do some background on vaccines, immunology in general, and then we're going to walk you through the updated guideline. Yeah?
Yes, sir. So types of immunization. Let's kind of go through active versus passive just briefly. So when we talk about like most vaccinations, we're talking about them inducing active immunity by basically promoting the development of an antibody in the patient that received the vaccine. So that response is going to then hopefully be prolonged, and they will have those antibodies present in case they ever encounter the virus or bacteria, whatever it is. Passive immunization is where we're talking about the administration of like a globulin product, which is going to help kind of produce this transient immunity for a specific exposure. So for instance, if someone was not able to get like a vaccine, like to go overseas, let's say, and they couldn't get their Hep A vaccine for whatever reason, maybe they would get some kind of a globulin product to sort of spike an immune response, but then it doesn't cover the same that an actual vaccine would. So when we talk about active immunization, the goal of that is to give a primary immune response. So we're hopefully going to be inducing B cell proliferation, antibody response, T cell sensitization, which also comes into play when we talk about like polysaccharide versus conjugate vaccines. So we'll talk about that a little bit too. And that's going to hopefully then, again, allow the patient's body's immune system to recognize a pathogen and hopefully take action to keep the patient safe. Passive immunization, again, is where we're administering the actual antibodies themselves, and it gives us a short-term protection, and it's towards a specific pathogen. We'll tend to use these towards patients that are like immunocompromised or something like that, to kind of get them through that period of time. But it's one of those things that we would more so want the active immunization because it's going to be more effective and more long-term.
Yes, absolutely. And as we go through the schedules, we're going to focus on adults today. There is a lot of different things for children. We're going to focus on adults today. It is important to stick to the schedules as best we can, but it's not dire, I guess. So every effort should be made to adhere to them. But if, for whatever reason, a interval is prolonged, it's not necessary to restart a series of any of these vaccines. Actually, it's not necessarily recommended. If it's prolonged, then give the vaccine as soon as you can, and then adhere to whatever the schedule is from then on. So I think that's important to point out. Most adult vaccines, of course, are going to be either IM, intramuscular, or subcutaneous. Usually, we'll see that that's not always has to be the case, but usually it's over the deltoid muscle. Interestingly, you might be concerned about a patient who's currently anticoagulated. It is not a contraindication to getting a vaccine. And there was a study looking at the flu vaccines, either sub-Q or IM, and there were no greater adverse effects, including hemorrhage, with the intramuscular vaccines. Even though that's the case, they do recommend a 23 gauge or smaller needle, just in case. Apply firm pressure after giving the vaccine. Don't rub for a couple minutes, and that'll help with any bleeding issues.
I think the length of the needle is something too that never really gets. We either do the 5/8 inch for sub-Q, and then at least in my experience, almost always gets 1 inch.
Yeah.
But technically speaking, that's not 100% accurate, because if a patient is getting an intramuscular injection, you could use a 5/8 needle if they're a really lightweight adult. So if they weigh less than 130 pounds, you technically could get away with a 5/8 inch needle, which is we typically think of being reserved for sub-Q. But that can help your patient who's maybe a frail elderly patient that, we don't need to stick this giant needle in their arm if we don't have to.
No, I had many instances, not only of hitting bone. We always hear the stories about hitting bone, which fortunately it doesn't really hurt people. It just kind of feels like a bump. But many instances of these poor old ladies when I'd have this 1-inch massive needle that I'm sticking in, and then more than half the thing is sticking out of their arm, and I've already hit their bone, which they're still going to get the immunization, but it would be probably more pleasant to use a 5/8 inch at that point.
Did you have the conversation with them that you should probably start doing more shoulder press
to
sort of build their...
I talked to them about that resistance exercise.
Good.
Yeah.
Because they need to build up that muscle. Come on. You're going to have bigger delts than that.
But yes, I would switch to a 5/8 inch to avoid that. But when you're giving 100 a day, sometimes it's hard to, you don't even know who you're about. You don't even know, you haven't seen the person yet that you're about to immunize, and you're like, line up, everybody, 5 of you.
That is true.
Yeah.
In fact, speaking of not seeing the patient before immunization, I had when I first got licensed, I was doing, dispensing pharmacy and whatnot. And I want to say this was probably my first vaccine I'd given as a licensed pharmacist. I mean, I'd given tons as an intern, but I was at one of the busiest stores that, the chain that I was working for had, and they had a separate immunization room and all that cool stuff. And the tech was the person that was like kind of getting the paperwork done. And I saw who I thought was the patient, and, that didn't raise any sort of red flags, anything like that would be out of the ordinary. Fill out the paperwork, everything was good. I had my stuff together. I walked into the immunization room, and I kind of opened the door like with my back because I had all these papers in my hand. Sort of opened the door with my back, and I turned around. Turns out the patient who was actually filling out said paperwork was the caregiver of the patient who was to receive the vaccine. That patient had for some sort of accident trauma that had resulted in having both arms amputated at the shoulder, so no shoulder, no deltoid whatsoever on either arm to be able to give the vaccine, and also one of the legs, the patient's legs had been amputated at the hip, and so had one leg, and the patient was made me laugh harder than anybody I think I've ever had, because she literally said, oh, hang on, I'll be right there. She starts wheeling herself over with her one leg. She goes, I'm not as fast as I used to be. And it just had like the best sense of humor. So I'm like,
wait a minute, I thought this needed to go in the deltoid.
Yeah, and I'm like, okay, so what do you do when the person does not have said deltoid? And so I kind of I was brand new, and I just kind of in the moment just made a decision. I was like, hey, out of curiosity, where do people normally give you your vaccines to kind of, keep them from hurting and stuff? You go, oh yeah, just my hip or whatnot. I was like, okay. And I'm like, sure, Tdap can go on the hip, probably.
Probably good.
I mean,
it's probably fine.
And so I gave it to her hip, and then I'm filling that out on like the paperwork. And as I'm filling it out, I'm like, oh, this is going to get me in so much trouble. Because I'm
they have like things you can circle, deltoid.
Yeah, turns out hip was not on there.
Yeah, thigh, other, and you're like, other.
And I'm like documenting the heck out of it. And I remember the pharmacy manager like reading it because I was just filling it at their store. And he was like, whoa, what did we do? And I was like, it was me. And I was like, I made an executive decision. So I ended up calling like one of my old, I think it was actually Dr. Wirt, and asked him, I was like, what do you think if hypothetically? And he was like, nah, that would be fine. I was like, oh.
Just got to get in the muscle.
Yeah,
got lucky. I'd imagine on the insert it has something, right?
I'm sure.
Probably.
But yeah, definitely was not the best experience for my first vaccine as a licensed pharmacist.
Yeah, I've got many vaccine stories. One of which was a poor girl who I gave a HPV vaccine to, which, especially with the teenage girls, it's just high risk for passing out. Mm-hmm. So she passed out and went very hypertonic, like while she was passed out. And so we called like EMS, or her mom wanted to call EMS. We called EMS. She came to like 30 seconds later. She passed out again, did the same thing, kind of shook a little bit. So I kind of thought it was just like a vasovagal response, but maybe some hypertonia. But the mom was pretty convinced that she had a seizure. And so she kind of described it to EMS and kind of played it up a little bit and told them that she had a seizure. Went to the hospital. She told the doctor the same thing. So she was diagnosed with a seizure and was given Keppra, can't drive for 6 months, all that kind of stuff. And I was like, I mean, maybe, but I'm thinking, I mean, I'm not a doctor, but I don't think she had a seizure. And
I'm not a neurologist anyway.
I mean, I wasn't confident, so I wasn't going to like contradict the mom in the moment or anything, but I always use this as example when I'm doing top discussions with my learners, because to describe how difficult it is to diagnose a seizure based on like caregiver, a witness's description, and how it can be biased. And, she may or may not have had a seizure, but now that's on her medical record the whole rest of her life. So.
Yeah. And probably, I mean, especially with that one, that's such a high likelihood of having a vasovagal response.
I know. It's the one that's known for having a vasovagal.
Right.
So it seems likely, but people do have seizures from vaccines sometimes. So
you get on the phone with the EMS after the mom did it. Oh my gosh, you are not going to believe this. We have a human EEG here that can determine whether someone's had a seizure just by looking at them. Yeah. Anyway, so needle size. Back to that.
Yeah.
The 1 inch needle is the one that I think commonly we end up using. However, there's also recommendations for a 1.5 inch, which I know it seems like not a big deal, but I feel like that's something that gets overlooked quite a bit. And really the cutoff is if it's a female patient weighing 200 pounds or more, or a male patient weighing 260 pounds or more, then the ACIP wants you to use a 1.5 inch needle. At least in my experience, I don't feel like I've ever seen people swapping that out.
I have never seen somebody swap that out.
So, I mean, just food for thought. Make sure that we're kind of paying attention to that.
Yeah, so 90-kilogram woman would be, almost 200 pounds. And then 118-kilogram man would be like...
Yeah, and they say...
That's like 230 pounds.
Yeah, they give it in pounds. They say 200 is their cutoff.
I'm sorry, I was reading kilograms, so I didn't even hear you.
Cole's always doing that. He's always reading kilograms. But
listen, we have international listeners.
That's true. That is very good point. Thank you, Cole, for keeping us honest. Mm-hmm. But yeah, so needle size can make a difference.
Interestingly, they do mention that gluteal administration should be avoided for standard immunizations. The immunogenicity of the Hep B vaccine is apparently diminished when given in the buttock.
Well, so I give Tdap. But again, if the patient does not own...
I was going to say, that's for people who have deltoids.
Right.
Yeah. You made the right decision.
Thanks, man. Appreciate it.
Good job.
I felt good about it.
Something that happens
7 years later.
Something that happens a lot is the opportunity, especially if you're in the retail pharmacy setting. This is pushed on you a lot, from pushed for you to push.
Yeah.
Right. Is vaccine co-administration and taking advantage of a patient getting a flu vaccine to say, hey, you need your pneumonia vaccine, so we're going to give this to you as well. Vaccine co-administration in general is okay at different sites without compromising efficacy. They studied the pneumococcal plus the flu vaccine. That it appears to be safe. There was a Finnish study. Those are people from Finland, Mike.
Thank you.
There's a Finnish study, about 10,000 individuals, 65 or older. About half received the pneumococcal vaccine and influenza vaccines together, and experienced approximately double the number of local reactions and fevers. So that's important to know that they might have a little more of a irritating reaction to it, compared to about the other half who received influenza alone. So maybe higher rates of some adverse effects, but immunogenicity appears to be okay.
Yeah. Unless of course it's I think the only time you have to actually worry about like co-administration is the live vaccines.
Oh, okay, it's just for live.
So if you have, you can give them together, which is fine.
Yeah.
But if you happen to get one and then wait like the next day, you have to then wait a 4-week period. But otherwise, it doesn't matter.
Right. Should be administered same day, but otherwise, if not, separated.
Yeah, that's the only I would think exception to that.
That's what you're
saying. And then as far as like contraindications, because when they're filling out their paperwork and whatnot, it asks them all kinds of questions about are you feeling sick today, blah blah blah. Some things that are not contraindications to getting an immunization. If the patient has current or recent like mild illness, even if it has a low grade fever, it's not a contraindication. Obviously, if they're really sick, we want to make sure that we're getting the optimal immune response, and we may want to hold off. But if it's just very mild, even if they have a very mild low grade fever, it's not a contraindication.
And they're always going to ask you.
Yes.
They're going to say, "Is it okay that I'm sick?"
Or if they're on antibiotic therapy, even if it's been recent, or if they're currently still on antibiotic therapy, it's still not a contraindication. You can give them that.
Still give it.
If they have a family history of adverse reactions to immunizations, not a contraindication. That's why we have EpiPens and Benadryl IM, available, and things like that. Because in the off chance that they happen to have a reaction, we can treat them accordingly. But it's not a contraindication. If they've had previous mild to moderate local reactions from the vaccine, still, again, not a contraindication, just an adverse effect.
Yep.
And so it's one of those things that, I think the way that from a paperwork standpoint, it can throw people off when they're, I have a little bit of a fever. Oh, okay,
they have to fill out the questions and check the boxes, and it's always going to ask like, are you currently ill and all that kind of stuff.
Yeah.
And they can say yes to that. It's good for you to be aware, but it doesn't. Maybe you'll ask some follow-up questions or whatever. But
that's more what it is, just to make sure you're asking those follow-ups.
Yeah.
Same with if they're on anticoagulation, still, again, not a contraindication. You just need to make sure that maybe you need to hold pressure on it a little bit longer if they're not, clotting after the injection, but it's not anywhere near a contraindication.
I've had people the blood squirt out. Like needle comes out and here we go. Nice little squirt of blood.
Right in the eye.
Right in the eye.
That hasn't happened to him, luckily. But
have you had a situation with your son with anything projectile in the face?
No, not in the face. I did watch some projectile substance get on my wife's arm though, and it made me laugh really hard because she just froze, and she was trying. She, in her defense, she handled like a trooper. However, it happened and just like splashed on her arm. Splash is not probably the right word. More viscous, and she was trying so hard to hold it together, and she was going, "What?" I was like, "Oh, you're doing great, babe."
My first experience was in the hospital. They have like the meconium feces or whatever that's like really thick like tar, and I was just changing him, and I guess he decided to spew some of that out, and I wanted to make sure everything was very clean, so I had him hog pulled up, and I was looking directly in there, and then just right in the face.
What?
Oh yeah, poof.
Oh, did you get conjunctivitis?
I handled like a champ.
Good.
I'm sure it's not that gross. They're newborns. It's it didn't smell bad. It doesn't smell bad.
Yeah.
So.
Well, I'd still prefer it not in my face, but
yeah, it's not ideal.
Yeah, but that's okay. Good for you, man. That's good. Welcome to fatherhood.
I don't know how we got there.
Yeah. Well, anyways. What do you want to tell us? Is that enough background information? You want to jump into some of these?
Let's jump into some vaccines. So, what we decided to do, as opposed to just confusing you with just going through the whole entire schedule of them, we're going to take this more on a vaccine to vaccine approach, give you information about each, tell you when it's used, some tidbits to know about it, and the updates. And we'll hit, as we go, we will hit the updates related to those vaccines, and we'll hit the new vaccines that have come out, and hopefully give you a nice overview of adult vaccinations.
Hopefully.
How do you feel?
I feel like, feel confident.
Great.
Maybe.
So we're going to start with maybe some lesser known ones. We're kind of going in alphabetical order is probably the best way we figured to do this. So the H-flu type B vaccine, abbreviated as
the HIB.
The HIB, H-I-B. So it has a couple of brand names, ACTHIB, Hiberix, PEDVax, H-I-B. So you might see this more in the kids. But it does have some reasons why you wouldn't be able to use it. Of course, a severe allergic reaction, or a history of allergic reaction to dry natural latex for those three brand names that I mentioned. And you want to use caution in a patient who is acutely ill. You might want to use caution there. But there aren't any updates to the immunization schedule for this one. And as far as when it's used, it is, I mentioned it was mostly for kids. I don't know why I said that. We're talking about adults. This is for adults. But when it's used, it's either a 1 or 3 dose series, depending on the indication. And this is kind of at any age range for adults, 19 to over 65 years old. The indications that would maybe adjust the amount that you get in immunocompromised patients, excluding HIV infection, then specifically for hematopoietic stem cell transplant patients, they get 3 doses. Otherwise, examples like patients with asplenia or complement deficiencies would get 1 dose, and so on. That is the HIB vaccine.
And that's HIB isn't with a B, not V.
Yes, H-I-B as in boy.
There we go, just in case.
Yeah, I'm sure there are some... well, I won't get into that, but there is no HIV vaccine that we're aware of.
Yes, that we're aware of. We have not been consulted on such a thing. The hepatitis A vaccine, there's no new recommendations there either. Basically, they just kind of recommend it again, not giving it if the patient has moderate to severe acute illness, but no new changes there. As far as kind of like the routine vaccination with Hep A, basically it's a 2-dose series, and patients. There's also a 3-dose series as well that you can get if it's in combination with Hep B. Those are Twinrix is the brand name that's available. So that's the time it's a 3-dose series. But typically it's used in situations where the patient has some kind of liver disease. So I personally see this a lot with our Hep C patients. So if they're not immune to hepatitis A, we'll go ahead and get them that vaccine at that point before starting treatment. Our patients who are at higher risk for contracting hepatitis in general, so patients who inject IV drugs, or patients who are experiencing homelessness, obviously patients who are working in close proximity to patients that may be from areas where that's high endemic rates of hepatitis A, or if you're working directly with the virus, you probably want to go ahead and get that vaccine. But it's as far as the actual routine recommendations, it hasn't really changed anything.
Yep. So that's Hep A. We also have a hepatitis B vaccine, right?
We do.
So Mike mentioned the Twinrix, which is the combo Hep A, Hep B, but there are a few brand names of the Hep B alone. The Ingrix B, Recombivax HB, and the Hepislav B. There are some situations where it would be contraindicated, and this is just severe anaphylaxis, of course, and then Hepislav B in particular is contraindicated in pregnancy. Hepislav B. As far as changes, so we do have some updates to the Hep B vaccine with the 2022 guidelines. So they're recommending universal vaccination to all adults 19 to 59. So that's different than what we had before, right? What we're used to is recommending it to patients who may be at high risk. I always think of diabetic patients who inject as being at higher risk for hepatitis B infection, but I'll go over some other patients who are at higher risk. But they're recommending universal vaccination, 19 to 59. Above 59, so 60 and older, they're recommending it with patients who have specific risk factors, which I'll go over in a minute. But that's the only time it's indicated there.
And I think it's one of those things that they left it open-ended like that because obviously it's not going to hurt them to get the vaccine. But yeah, I think that before it was very specific about who was a candidate, and I think it's a good idea to include all adults because not one of those that we want to run the risk of getting.
Right, I agree. Depending on the brand name that you're using, it's the amount of injections will differ 2, 3, or 4 doses. As far as patients who are at high risk, like special situations, chronic liver disease, HIV infection, potential risk with sexual exposure, injection drug use, people who are incarcerated, diabetes, that sort of thing. So.
Well, and the thing with from a patient who may be at risk from a sexual exposure too, one way to kind of evaluate quickly, I think we talked about this when we've talked through some of the Hep C, topics before, but checking a surface antigen. So Hep B surface antigen level is kind of indicative of a acute Hep B infection. So if someone were to have a sexual encounter where the partner had a surface antigen, Hep B surface antigen that was positive, then at that point you may want to go ahead and consider vaccination to try to hopefully prevent the virus from infecting the patient.
Yep.
And so, if you're ever treating someone with Hep C, for example, or any kind of other like liver disease, and you're doing routine Hep B screening, and their surface antigen is positive, that means they've already obviously have an acute Hep B. But if their surface antibody is negative, that means that they have not received immunization. And go ahead and give them the needle.
Give them the needle.
Yeah, that's my catchphrase.
Yeah, shoot them.
No, don't say
Shoot
that.
Shoot them.
Is that what we say, Cole?
Shoot them.
That's our T-shirt now.
What is that from?
Available. I have no idea.
It's from that. You don't know what that's from?
I don't know what that's from. I thought you were just doing a voice.
No, my football coaches used to holler that. It's from an old Discovery Channel show where they would hunt alligators. Do you remember that in Louisiana? No?
No. An alligator show? Is it a movie or was it an actual documentary show?
No, maybe it was crocodiles. It was like a documentary. Not a documentary, but it was like
crocodiles in Louisiana.
Yeah, it must have been alligators. Gators. Yeah, it was gators.
Yeah.
Because they had the Louisiana accents. Jeez, I can't believe you've never seen this.
I can't.
It was reality, it was on documentary. It was reality television where they would go and they hunt alligators in Louisiana.
There you go.
And, they would they would shoot them and they would, they would they would haul them up to the boat and then they'd start hollering, shoot them, and they'd shoot them.
Sounds like a good show. Every episode is very similar.
Listen, I'm just trying to make relevant pop culture references
from a show that aired
from 2000
years ago.
9. Yeah,
that's good. Cole's an old soul, if you will.
Jeez.
HPV vaccination?
Yeah, go ahead while I look up what the show's called.
Okay, thank you. Yeah, because we are all dying to find out, so we can make sure we all watch that. I'm just kidding. HPV vaccination. So recommended for all patients who are under the age of 26. So usually we start the initial vaccination at the age of 9, in the range of 9 to 14 years of age. And at that point, if the patient has started their vaccination at 15 years of age of older, then they do a 3-dose series, and there's a 2-dose series as well. And we won't go into all that, but it's basically, we've historically we've thought of this as being something we've given to younger patients. However, over the last couple of years, there's been more data coming out that shows that there's some benefit here for older patients as well, and adult patients. So there's some shared clinical decision making option for getting HPV vaccination for patients who are at the age of 27 to 45 years of age now, and it can be a 2 or 3 dose series depending on when the dosing interval was given and all that. But it's our older patient population, I feel like, is something that is important to consider when historically we haven't really thought of that as being one of the vaccines to give patients. And if a patient has any kind of no history and they need a routine catch-up for their vaccination for HPV, that's going to be important. Or if they're some kind of an immunocompromising conditions, or if it's a pregnant patient, you need to give vaccination to, then you need to hold off until after pregnancy.
Right. So that's HPV.
Mm-hmm. And now I will say, if you do vaccinate a pregnant patient, there's kind of a caveat. This is, if you inadvertently vaccinate a pregnant patient, you don't have to do anything in particular. It's just typically we wait until after.
Yes.
All right.
So I'm going to go for the big one, right?
What you going?
Influenza.
Ooh.
Comes right after HPV.
It does.
So, let me know what I missed. But so flu vaccine. So in some ways it's simple, in some ways it's not. There are a multitude of brand names for the inactivated influenza vaccine. But then, of course, we're going to try to highlight when there are live vaccines, because there's only a few. So we're going to try to highlight those. There is a live attenuated influenza vaccine branded as Flu-Mist Quadrivalent. There's also a recombinant influenza vaccine, and that is Flu-Block Quadrivalent. And those are all slightly different. As far as contraindications, so I'll touch on those here. I'll touch on those when I'm talking about the schedule. But there are egg-based influenza vaccines, and so a severe allergic reaction to egg component would be an issue there. And then there are also branded vaccines that do not involve eggs, and so that's what you would want to use in that instance. There is a risk for Guillain-Barré syndrome, of course, within 6 weeks after a previous dose of any type of flu vaccine. So if they've had Guillain-Barré before, then that would be a precaution, not necessarily a contraindication, but a precaution to getting another flu vaccine, and that would be kind of a risk-benefit situation there. I think I'm going to hit the rest of the contraindications with the live vaccines when I talk about the schedule. But basically, we're mainly talking about adults, but this one's kind of easy to say. Basically, all individuals who don't have a contraindication 6 months and older are recommended to have a flu vaccine, 1 dose annually. So in that sense, it's easy. But there are some situations where the live vaccine, for instance, is contraindicated. So I just want you to be aware of those, even though, do we really use the live vaccine?
I mean, I can't tell you the last time I even saw anybody get flu mist.
So if you recall, it was taken off the market for being no better than placebo for like, what, a year, 2 years?
Yeah, something
Put
like that.
back on the market. The only real reason I can think to use it is if somebody just really doesn't want an injection and wants a nasal spray.
Yeah.
That's the only reason.
Of course, there also is the jet injector, remember, where it pushes the high pressure stream of fluid that penetrates the skin instead of using a needle.
What?
Yeah, Afluria vaccine jet injector.
What?
Yeah, you haven't seen that?
No.
Yeah, it sounds insane. Like, well, you don't want a needle, but you want this stream of liquid
This
to be shot. It's
burst
high,
of liquid,
yeah.
this shotgun of liquid
Right.
shot into your arm.
It seems preposterous.
Hey, it's needleless.
It is technically needleless. It's going
know-
to hurt a lot.
You know why I believe that?
Huh.
Have you ever used a water pick?
Well, because it's true.
Have you used a water pick?
No.
Okay, so they work wonders. It's instead of having to floss, which do you floss? Mm-hmm. Do you? Mm-hmm. Okay.
I mean, probably not as often as I probably need to, but
well,
yeah.
I'll be honest here. Okay, don't floss. Should I? Yes. Do I? No. But I
free
do.
country, man.
I do occasionally use my water pick, which is supposed to be better than flossing. And those things are powerful. So a water pick is like it pulses water in between your gums.
I have seen that. Okay.
Yeah, powerful. I could definitely imagine if I cranked that thing up, it could break the skin in my deltoid.
Maybe.
Listen, you know what I do?
But your gums don't get broken from it?
Listen, when around the room of your sink in your bathroom when you neglect it, lots of soap scum and mildew.
Sure.
Crank that water pick up to max. Tilt it, aim it towards the mildew. Bang, 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 bang. Cleans it all up. You're gonna have it splattered all over your mirror,
Right.
but it takes it right out instead of having to like rub it down with a toothbrush or some nonsense.
Well, the things we get to learn in this podcast.
Listen,
One time I sprayed my foot with a power washer by accident. It took the skin right off that. And so I imagine if that was a vaccine.
I mean that's effectively what a water pick is. It is a pressure washer for your teeth.
Right. Sounds like you need to just get floss.
Well, I will be honest. I hate flossing.
Yeah, I hear you.
Okay, so just so you know, even though you might not see it or you might see the Afluria injector, the live vaccine contraindications: do not use in pregnancy, do not use in immunocompromised, HIV infection, don't use, asplenia, complement deficiencies, don't use, and then precaution in patients who might be at increased risk for infection but aren't necessarily immunocompromised in that sense: diabetes, chronic liver disease, heart or lung disease, alcoholism, end-stage renal disease, or dialysis. Otherwise, everybody else can get it 6 months and older. Is the live vaccine approved for 6 months?
I think it's
Don't quote me on that. Sorry, but flu vaccine in general.
If only we had looked that up.
I know flu vaccine in general, 6 months and older. Everybody can get one.
It's definitely not 6 months.
The live vaccine is not down to 6 months, so forget about that. I'm talking about adults, but just in general, a flu vaccine can go down to 6 months.
There you go. Yeah. There you go. Also in older patients, so we have 65 and over. We have the high dose quadrivalent, the Fluzone high dose, and then we also have Fluad still on the market as well. So Fluad is basically the standard flu vaccine with a squalene emulsion adjuvant added to it to hopefully increase the immunogenicity of the vaccine. And then the Fluzone high dose is just a higher dose of the vaccine that we would typically give to a younger patient. Historically, they've kind of just said, pick whichever one is available. I know when the trivalent, when the Fluzone high dose was still a trivalent vaccine, they had actually done like a head-to-head comparison with the standard trivalent vaccine, and it was superior. I think the number, if I remember correctly, I don't have it in front of me, but I think it was like 218 was the number needed to treat, which from a cost-benefit analysis actually was a good thing to get the higher dose for those older patients when you consider how many patients you're getting the vaccine. But however, the Fluad was not really any different. Plus, it had more adverse effects because of that squalene emulsion. So I know me personally, I tend to lean towards the Fluzone high dose. But if a patient is needing the vaccine and Fluad's all that's available, then that's obviously still an option. But they're not necessarily equivalent per se, even though they haven't been compared head to head.
Right. Yeah. The guidelines don't really give preferences, but since we evaluate literature critically, we can determine our own preferences. Ish. Critically ish.
Asterisks.
Asterisk beside that.
So influenza vaccine, when that's coming up, it's
a time.
It is. It's about that time. Because
Yeah, it is.
so middle August. So ideally,
I bet the
usually
shipments are
around
coming in, man.
October.
Yeah.
is when we're usually trying to get it.
Yeah, but I remember we would get shipments late August, early September, and we'd try to get as many people done as we could then before the onslaught in October, because all the doctors say Halloween.
Yeah, that's
That's how they tell people to remember.
Yeah, which I mean, I feel like is a good, because the patients who get it in like early like August or even like July, if it's available, it's like
It can. I mean, it can
flu
lose.
Season's not until February,
Yeah,
so
it can lose it, especially if you have a late season. It can cause some problems. Yeah.
So I don't know. Anyways, you want to jump to pneumonia, since that's kind of a new.
Sure.
So for those of you who remember the very hard to keep track of previous pneumococcal vaccine guidelines, where the patient, if they had certain conditions, then they could get the PPSV23. If they had other conditions like HIV or immunocompromised, then they could get the PCV13 or Prevnar 13, which is the conjugate vaccine, and then they'd have to get the Pneumovax vaccine. It was just this whole like,
how many I don't know. I felt like I spent many hours trying to get all that nonsense straight and then re-looking it up because I forgot exactly how it needed to be.
I talked about it so many times, like with students or like,
and now it doesn't
matter.
Doesn't matter.
So many things like that's going to happen though.
I know.
So now we have a new Prevnar. It's not just 13 anymore.
No.
We have Prevnar 20. PCV 20.
They didn't go up to 17.
They sure didn't.
They didn't stop at 18.
Nope.
They didn't even stop at 19.
All the way to 20. They did, however, stop at 20.
They said, nope, no more.
No more. And we also have another conjugate vaccine available that is produced by Merck, I believe, the PCV 15.
15.
I was joking like with one of the drug reps from Pfizer, and I was kind of like, could you imagine how mad? I mean, I know this isn't exactly how it played out, but it makes it funnier in my head. If they were like, yeah, we get this new, PCV vaccine coming out, it's gonna be great. It's got 15 serotypes that it's gonna cover instead of the Prevnar 13, and then they find out that Pfizer's got a new Prevnar 20 coming out. They're like, crap. Yeah. That just made me laugh.
If you're wondering, the PCV 15 is branded as Vaxnuvance.
Yeah.
That's kind of a strange name.
I'm not a big fan of that name.
Me either.
But the problem with, not the problem, but the issue I personally have as far as recommending that one to patients is you still have to follow that one up with PPSV 23.
Wah, wah.
Yeah, and so the old school Pneumovax 23 is still in play if you use that one. If you use Prevnar 20, you don't have to worry about it. You can do one and done. And Prevnar 20 basically is just instead of being only for patients who are 65 and over, like the previous, or immunocompromised, now all those conditions that we previously would treat with Pneumovax 23, we can now just kind of also include with the Prevnar 20 group.
Yeah.
And so you can get it at a younger age. And
so much easier.
So much easier.
Just like any adult, PCV 20, call it a day.
Yeah. It's a lot easier. God. And the data is so much better than it was with 13 too.
Yeah.
So that's good news.
Is 13 even available anymore?
Yeah, because
nowhere in the guideline. Kids is kids, yeah.
And I think it's still gonna be a year or two before PCV 20 is available or approved for kids. But yeah, so we keep it because we have a peds wing.
I see.
So
for adults, it's not even listed in the guideline.
Yeah. So keep that in mind. And just to throw this out there, the difference between the polysaccharide vaccine and the conjugate vaccine, because that is something that's important to kind of keep in mind, and why we always prefer to use a conjugate vaccine. If I'm giving a polysaccharide vaccine, it's basically just like mimicking the outer polysaccharide like coat of the bacteria that it's, so like in the instance of Pneumovax 23, you have that polysaccharide coat so that B lymphocytes and whatnot can bump into that and recognize that and produce antibodies and what have you. You're not getting any sort of T cell activation though, because once it engulfs the that coat, it's not able to actually present anything on the cell surface, like utilizing an antigen presenting cell, and then get T cells involved. So you sometimes see like polysaccharide vaccines is referred to as like T cell independent vaccines, because you're really just getting the B cell activation and on that side of things. Whereas a conjugate vaccine takes that polysaccharide coat and they also conjugate, like in the case of Prevnar, diphtheria carrier proteins to that polysaccharide coat, so that now you actually have something to present on the cell surface that gets T cells activated, and then you kind of go from there. You get a much better immune response. which is why previously we would do 13 before 23, because even though it doesn't cover as many serotypes, you kind of prime the immune system, so to speak,
Right.
and get it ready for the polysaccharide. It's also why we don't give polysaccharide vaccines to younger, like kids, like newborns and stuff like that, until at least, I think, 2 years old usually.
Right.
So definitely conjugate vaccine is going to be a much better immunogenicity response.
Right.
There you go.
I did want to briefly mention the MMR vaccine, which is a live vaccine. No updates there. It's recommended 18 to 65 unless you have a contraindication. And then the meningococcal vaccines, which there are a number of them, and then there's a couple different serogroups to be aware of. There's the ACWNY, branded as Menactra, Menvio, or Menquadvi, and then there's the serogroup B, Bexsero, and Trumenba. They're recommended at any adult age unless you have a contraindication, and the doses kind of vary depending on which one you get.
Yeah, and also the Menactra is the conjugate. Because what's I don't have it in front of me now. I'm trying to pull it back up. There's one of them, the meningococcal that's covers those 4 serotypes, but it's the polysaccharide vaccine. So make sure it's the conjugate is the one that's typically recommended. Have you seen the commercials for? I want to say it's the Bexsero. It's one of the. I think it's one of the meningococcal B.
The very sad one about
the kid's like talking to the picture.
Yeah.
And he's like, if
my mom had only vaccinated me for meningitis B,
he's like, I would be here.
I would be alive.
But you didn't know though, right?
Know,
right, Mom?
I know.
Like, that's the most disturbing commercial.
What
of all
is it? The
time.
FTC who's supposed to regulate that kind of stuff?
I don't know.
Federal Trade. I think.
I feel like we need to do a better job.
That's pretty brutal, dude. Have you seen the shingles commercial recently? The Shingrix vaccine?
No.
It's a little disturbing, but like it's this guy and he's just talking all chill, and then he lifts up his shirt and he's like, yeah, this is my buddy over here. And it's just this nasty shingles infection on his stomach. And I'm like, yeah, anybody who sees that will get the shot because it looks disgusting. Like it's just a very accurate depiction of a pretty rough shingles activation. It's disturbing.
Well, there you go.
I mean, if that's helpful, that's good. I don't know about like my mom had only
the kid talking
got me the
picture.
meningitis because
that's probably the worst one.
It's one of those things that you have to get before like college and stuff, right? Because it tends to go around in like dorm rooms and things like that.
Yep.
Yeah. So, anyways, MMR, meningitis, no updates.
What's next? What do we got?
Tdap.
Yes. So I think the big thing with Tdap is that we used to say that you get the Tdap at one point, per lifetime, unless it's a pregnant female or something like that. And, then when we needed a tetanus booster, you could do just that. Now they've kind of moved to where you can get the Tdap as your booster. And use that as, instead of you getting just the TD, you can actually get the redosing of the pertussis component as well, which I feel like that obviously makes sense,
right?
And that's something that is still recommended at every pregnancy, even if the patient's had their Tdap previously. If they become pregnant again, then they want to revaccinate again.
Yes, tetanus, diphtheria, and pertussis.
Yes, specifically for that pertussis component.
Whooping cough.
Whooping cough. I had whooping cough. That's not fun.
It's a weird experience when you have a kid and you're like, hey, everybody, did you get your Tdap? Like, just
you better
make sure you got your whooping cough vaccine.
Or don't come over here.
They're like, it's like, oh, fine. I'll be like, no, I really don't want him to get whooping cough. Please get the vaccine.
I'm not trying to get my son whooping cough, if you don't mind.
It's just not ideal.
It's really not.
We have the varicella vaccine, branded as Varavax. No updates to the routine vaccination schedule. So it is still recommended in 18 up to 65, unless you have contraindication, which would be instances like pregnancy, because it is a live vaccine, or immunocompromised individuals.
Did you have chickenpox when you were a kid? Do you remember?
Did you?
Oh yeah, horrible.
Yeah.
And my parents put what was that? The calamine lotion.
Yeah.
And
didn't we just talk about calamine lotion?
Maybe
we did.
What
was that about?
I don't remember.
Okay.
But I remember. So this is one of those weird memories where, like, I feel like I remember it, but I think it's just because my dad told me, because he thought it was funny at the time. He was like, "Yeah, you were covered head to toe in this, and we had you all this." And he's like, "No," and you were just like sitting there all with your arms up like this, and you're like, "I'm covered in this pink stuff now too." He thought it was funny. I was like, "I'm probably traumatized."
No, I guess I got the shot and never had chickenpox.
Never had it. Right on.
Yeah.
Well, there you go.
Speaking of which,
yeah.
the next vaccine.
What, zoster?
Yeah.
Tell us about it.
Me?
Yeah, dude.
All right.
I feel like you were on a roll here. It's,
Okay.
It's basically the same kind of thing.
Rocking and rolling. So the zoster vaccine. So there's the old Zostavax live vaccine.
Yeah.
Not really using that. Don't worry about that one. New one, Shingrix. Much better efficacy, non-live.
Much better.
That's what we got. As far as recommendations, there aren't actually any updated recommendations. They changed some wording in the guideline, but none of it is specifically, I guess, not exactly important. They talk about pregnancy. They don't give a recommendation about pregnancy, but they do say consider delaying it until after. So
And it's because we can give it to younger patients if they're immunocompromised.
Yes.
Because you typically save it for patients who are 50 years of age and older.
Right.
But they will consider, because it's not their original live vaccine, if they're immunocompromised, they will give the series early. So that's where the pregnancy thing really comes into play.
right. So it can be used in any adult patient who is immunocompromised. Still the 2-dose series. Yeah. So that's awesome. I have an interesting anecdote. We had a visit from our district manager. So not our regional manager, but like person above that district manager.
This is when you were working like in dispensary?
Yeah, this is when I was in retail. It was early on, I believe, because I wasn't PIC at that point. So our pharmacist in charge was there. And part of what we were doing at that time was pushing, flu vaccines, but also pushing subsequent vaccines and whatnot. And so we would look them up on the vaccine registry when they got a flu vaccine, and we would offer them whatever they were missing, right? So she had one of the technicians, the district manager had one of the technicians look, had her look her up to demonstrate that she knew how to do it in the vaccine registry or whatever. So she looked her up, and then she had the pharmacist come over and take a look at it, and he's like, "Oh, you're due for your shingles vaccine." And she was like, "Oh, okay, yeah." And he's trying to be like, "Oh, yeah, we push these hard, right?" And so he's like, "You're due for your shingles vaccine. Why don't we get it today?" She's like, "Okay." So he gets the Shingrix together, and he was around for the era of Zostavax. So I guess he was nervous or something. Gave the darned shingles vaccine, which should be IM. Zostavax was sub-Q. Stuck the 1-inch needle up the back of her arm and gave it to her sub-Q.
Heck yeah.
The district manager.
It might have been he just didn't like the district manager.
He came up to me afterwards,
So
like a few minutes later when he realized, he's like, "Dude, I just gave her the Shingrix vaccine in the back of her arm." I said, "What?" He's like, "I don't know. I just got nervous."
I got nervous. I panicked.
I was like,
That's
"How
pretty funny.
could you do that?" So
was the district manager a pharmacist?
yeah.
Well, how do they not know?
She did, but I guess she just let him do it because I don't know. He was probably just in the middle of it. Maybe she was so shocked. So he addressed it and apologized, and I guess she's gonna have to get it again.
Oh, yeah,
I don't know. It was a 1-inch needle. Do you think it could have gotten through the sub-Q tissue and into some muscle? I doubt it. Right?
I don't know. I mean, I guess to be it's not gonna hurt to get it again, probably.
No, she'll just get it again. But
get it again.
how mortifying for if that happened.
It's pretty
it
funny.
wouldn't happen to me because I'm not. I don't know.
Because I wouldn't have panicked.
I know. Oh gosh.
I'm always calm, cool, and collected. That's the thing.
I was like, come on, man. How
Yeah.
did you do that?
It's just a person, right? You don't have to be that nervous. That's what that person gets for showing off in the first place. Oh, we push these vaccines hard.
Golly, that
I don't miss
stresses me out
that
to
at
think
all.
about.
Anything else with these? I know.
So the big change is with the new pneumococcal vaccines. Obviously, we have the COVID vaccines. We talked about them in previous episodes. We're not going to go into all the weeds, but just obviously be aware that they're out there. They are approved down to 6 months for the Pfizer vaccine, 6 months for the Moderna vaccine, 18 and older for Janssen vaccine, and then there's a newer one called Novavax or from Novavax. I'm not entirely sure, but it's newer, 18 and older for it. And yes, there are, of course, different doses, different dosing schedules for all of them. But they are out there.
There you go.
We preferred not to get into the weeds on that since we covered it relatively recently on a different episode.
Right.
In pretty significant detail, right?
Maybe.
I
don't remember.
don't remember which episode it was.
Yeah, it's been a minute. But I think there's a company that's also working on a dual influenza and COVID vaccine that's together in one vaccine, I believe, too.
Really?
Yeah. Which, I mean, that's what it's going to turn into. It's going to just be an annual vaccine, is my guess.
I guess.
So,
yeah.
Yippee.
It's another shot to get.
Yeah. Well, it is what it is, I guess.
Yeah.
Cool. Anything else, man?
That's all I got.
All right, guys. Well, make sure you go to the show notes, check out the link. Password is vaccine. take that test. If you are unable to take the test, it's because you're not a member, and you got to become a member. Become a member. Join the cool kids. Check out freece.com. Again, thanks to them. And as always, I want to give a big shout out to our main podcast sponsor, Pearls. Thanks to them for continuing to sponsor the podcast. If you've not checked them out, the app or the website, Pearls is PYRLS.com. Go to /CorConsultRx, and you can sign up for a free account. Check out the app. Check out the charts, all the good stuff they have available. Definitely a solid tool to add to your arsenal of clinical tools. But no, we definitely appreciate them continuing to sponsor the podcast as well. And check them out and let them know that we sent you, so can kind of help support the people that support us, and go from there. But thank you guys so much for listening. If you have any questions or comments or anything, make sure you send us an email, or you can reach us on any of the social media platforms. The number that you can text us directly is in the show notes. And thank you guys for hanging in there with us. We're slowly approaching episode 200. You guys thought I wasn't going to mention it this episode, but there it is. Saved it for the end. But yeah, thank you all so much. It really does mean a lot to us, all of our listeners and supporters. And if you want more traditional lecture styles, don't forget about the patreon.com/CorConsultRx. Download all the slides, get actual lectures, and feel like you're in school again. So yeah, we'll see you guys around on the next episode. Have a great one.